Most people over 60 don't realize this, but some of the very medications keeping their blood pressure stable are silently pushing their kidneys toward decline, and there are no warning signs. No pain, no signal, nothing to tell you it's happening until a routine test changes everything. The question is, how long has it already been happening to you? If you're serious about taking better care of your health, make sure you subscribe. I share simple, practical advice designed especially for seniors. And feel free to leave a comment telling me where you're watching from. I appreciate every one of you. Let's get back to it. Every morning, without thinking, you do the same thing. You reach for that small pill. You swallow it with water. You move on with your day. No hesitation, no second thought, because you've been doing it for years and it's working. Your blood pressure is under control. Your doctor is pleased. The numbers on the chart say everything is fine. And that's exactly what makes this conversation so important. Because fine and fully informed are not the same thing. I'm Dr. James Cross, and today I want to talk to you about something that rarely comes up during a standard 10-minute checkup. Not because your doctor doesn't care, but because modern medicine is designed to solve the problem directly in front of it. Lower the pressure, protect the heart, prevent the stroke. All of that is correct. All of that matters. But here's what doesn't get said often enough, especially to adults over 60. Every medication that helps one part of your body asks something of the rest of it. And when it comes to certain blood pressure medications, what they quietly ask of your kidneys over months and years is something most people never find out about until a routine blood test tells a story nobody was expecting. Here's what the research tells us. According to studies in nephrology literature, kidney filtration capacity begins declining gradually after the age of 40 at roughly 1% per year in healthy adults. By the time you're in your 60s or 70s, that decline is already in motion, quietly, and completely without symptoms. Now consider this. You're also taking one or possibly more blood pressure medications. Taken correctly, taken consistently, taken with complete trust. And yet, for reasons most people are never told, certain combinations of these medications can accelerate what was already quietly happening inside those kidneys. Not dramatically, not overnight, but slowly, accumulating, in a way that only shows up when enough function has already been lost. That's what today is about. I'm going to walk you through 3 categories of blood pressure medications that deserve a second look, not because they're dangerous on their own, and not because you should stop taking them, but because awareness is the only thing standing between you and a problem that has no early warning system. Your kidneys don't send pain signals when they're under strain. They adapt, they compensate, they do everything they can to keep up quietly, without complaint, until one day, quietly, they can't. And by then, the conversation has changed entirely. Let me ask you something honest. When you think about your health, really think about it, which organs come to mind first? Your heart? Probably. Maybe your lungs? Your brain? And that makes sense. Those are the organs that announce themselves. The heart pounds when you're anxious. The lungs tighten when you climb stairs too fast. The brain reminds you it exists every time a headache sets in. But your kidneys say nothing. And that silence, that complete, unbroken silence, is exactly what makes them the most vulnerable organ in this entire conversation. Here's what most people don't fully appreciate about what's happening inside their body right now, at this very moment. Your kidneys are filtering your entire blood supply, every drop of it, approximately every 30 minutes, 24 hours a day, 7 days a week, without rest, without complaint, without ever once asking for your attention. They regulate your fluid levels, they balance your electrolytes, they remove waste that, if left unchecked, would poison you within days. They even play a quiet role in controlling your blood pressure, which makes what I'm about to tell you particularly important. These aren't passive organs, they are precision instruments, and like any precision instrument, they have limits. Now here's the part that most people find genuinely surprising when they hear it for the first time. Chronic kidney disease, the kind that develops slowly over years, progresses without any noticeable symptoms in its earliest and most treatable stages. According to the National Kidney Foundation, approximately 90% of people with early-stage kidney disease don't know they have it. 90%. Not because they ignored warning signs, but because there were no warning signs to ignore. No pain, no visible changes, no dramatic moment that says, "Pay attention, something is wrong here." Just silence. The same silence your kidneys have always operated in. And this is what separates kidney health from almost every other health concern you'll encounter after 60. With most conditions, your body eventually signals distress. Something hurts, something changes, something pushes you toward a doctor's office. With kidney decline, especially the kind triggered by long-term medication use, the signal often comes late, after function has already been reduced, after the window for early intervention has quietly closed. There's a phrase I think about when I have this conversation. Silence is not the same as safety. Your kidneys can be under consistent compounding strain right now, today, and you would feel absolutely nothing different from any other Tuesday morning. That's not meant to frighten you, it's meant to reframe how you think about monitoring. Because here's the truth. The people who protect their kidney health aren't the ones who waited for symptoms. They're the ones who understood early enough that with this particular organ, by the time you feel it, you're already behind. So now you understand what your kidneys are actually doing. Every minute, every hour, every day, quietly filtering, quietly balancing, quietly keeping you alive in ways you never think about until something disrupts that quiet. And the first disruption I want to talk about comes from one of the most commonly prescribed medications for blood pressure in adults over 60, diuretics. You may know them by another name, water pills. And if you're currently taking one, you're in very large company. Diuretics are among the most widely prescribed blood pressure medications in the world, and for good reason. They work, they lower pressure effectively, they've been used safely for decades. But here's what the prescription label doesn't explain. When a diuretic enters your system, it sends a direct instruction to your kidneys. Release fluid, push it out, reduce the volume, and your kidneys comply because that's what they're designed to do. They increase urine output, fluid levels drop, and blood pressure follows. Simple, effective, logical. Except for one thing, most people over 60 are never told. Your kidneys don't just passively release that fluid, they work to do it. Every time a diuretic triggers that process, your kidneys are not resting, they are actively being driven to perform at an elevated level, pulling fluid from the blood and pushing it toward excretion. Now add this into the equation. A significant percentage of adults over 65 are already mildly to moderately dehydrated, not because they're careless, but because the thirst mechanism weakens with age. Research published in the European Journal of Clinical Nutrition has confirmed that older adults frequently underestimate their fluid needs and consume less water than their bodies actually require. So here is what's quietly happening for many seniors on diuretics. The medication is instructing the kidneys to release fluid that the body can't fully afford to lose. And the kidneys obedient, efficient, silent, comply anyway. Think of it this way. Imagine a water pump designed to run continuously. It functions perfectly when the reservoir behind it is full. But slowly, without anyone noticing, the water level drops. Nobody refills it. And the pump keeps running, pulling harder, working faster, doing exactly what it was built to do. That pump doesn't stop. It doesn't send an alarm. It just wears down. That is what chronic, low-grade dehydration, combined with long-term diuretic use, can quietly do to kidney tissue over months and years. And here's the detail that makes this particularly relevant for the over 60 population specifically. As the kidneys age, their ability to concentrate urine and conserve water becomes less efficient. This means that an older kidney loses more fluid per cycle than a younger one would under the same medication dose. The margin for error gets smaller, and the workload stays exactly the same. A review in the Journal of the American Geriatric Society noted that diuretic-related kidney stress is significantly underdiagnosed in older adults, largely because the early indicators, slight changes in creatinine levels, are rarely flagged unless someone is specifically looking for them. And most of the time, nobody is specifically looking. Not because of negligence, but because blood pressure is controlled. The medication appears to be working, and on the surface, everything looks fine. But fine on the surface and fine underneath are two entirely different things. And with diuretics, what's happening underneath deserves a much closer look than most people ever give it. So we've established what diuretics do beneath the surface. The fluid drain, the hidden dehydration, the kidneys working harder than anyone realizes, silently, without complaint, exactly as we discussed. But now I want to shift to the second medication on this list. And this one operates through a completely different mechanism, which means it creates a completely different kind of risk, one that is arguably harder to detect, and in many cases, harder to reverse. We're talking about ACE inhibitors. If you're over 60 and managing blood pressure, there's a very real chance this medication is already part of your daily routine. ACE inhibitors are among the most prescribed cardiovascular medications in the world. They relax blood vessel walls, reduce strain on the heart, and lower pressure throughout the circulatory system. Again effective, again widely trusted, again prescribed for good reason. But here's where the story changes. Your kidneys don't just receive blood passively, They regulate the pressure of the blood flowing through them with extraordinary precision because filtration only works within a very specific pressure range. Too high, and the vessels inside the kidney are damaged over time. Too low, and filtration becomes inefficient. Waste stays in the blood longer. The kidneys compensate. They strain. ACE inhibitors reduce pressure throughout the body, including inside the delicate filtration vessels of the kidney itself. For most people, the body adjusts. The kidneys find their new equilibrium. But here's the variable that changes everything. There is a condition common in older adults, and frequently undiagnosed, called renal artery stenosis. It simply means a narrowing of the arteries that deliver blood directly to the kidneys. You won't feel it. There's no symptom, no signal. But it affects a meaningful portion of adults over 60 with cardiovascular disease. Some estimates in nephrology literature suggest prevalence rates between 7 and 20% in this population, depending on underlying risk factors. Now consider what happens in that scenario. Blood flow to the kidney is already restricted due to arterial narrowing. Then an ACE inhibitor further reduces the pressure driving that flow. The kidney, already working with a compromised supply, now receives even less. A review published in the Journal of the American Geriatric Society found that in patients with undiagnosed renal artery stenosis, ACE inhibitor use could lead to measurable declines in kidney filtration within weeks to months of starting treatment. Not years, weeks to months. And because there are no symptoms in early decline, most people continue taking their medication correctly, their blood pressure looks controlled, and nobody connects the dots. The kidneys adapt, they compensate. Until the compensation starts showing up in a lab result that finally makes someone look closer. That's the pressure shift problem. Not dramatic, not sudden, just a quiet recalibration happening inside an organ that will never once ask you for help. So far, we've talked about two medications, two separate mechanisms, two different ways that commonly prescribed blood pressure treatments can quietly place compounding strain on your kidneys over time. And if the story ended there, it would already be worth paying attention to. But it doesn't end there, because the third factor in this conversation isn't a blood pressure medication at all. It's something far more ordinary than that, something sitting in medicine cabinets across the country right now. Something millions of older adults reach for without a second thought, because it's available without a prescription, it's been used for decades, and nobody ever suggested it could be part of a larger problem: pain relievers. Specifically, a class of medications called NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. The kind of relief people reach for after a long day, an aching knee, a tension headache, or the general joint discomfort that becomes increasingly familiar after 60. And here's the critical point. Used occasionally, by a healthy younger adult, NSAIDs are generally manageable. The body handles them, the kidneys process them, life continues. But that's not the situation we're describing here. We're describing an adult over 60, already on a diuretic, possibly on an ACE inhibitor, kidneys already navigating reduced filtration capacity, altered pressure balance, and the quiet dehydration that nobody flagged. And then on top of all of that, a routine dose of ibuprofen for a sore knee. Here's what that NSAID is doing inside the kidney at that moment. NSAIDs work by blocking certain chemical signals in the body, specifically prostaglandins. These chemicals serve many functions, including regulating inflammation. But inside the kidney, prostaglandins play a very specific and critical role. They help dilate the small blood vessels that supply the kidney's filtration units, maintaining adequate blood flow, even when the body is under stress. Block those prostaglandins and those vessels constrict. Blood flow into the kidney drops. And now, for the first time in this conversation, all three effects are present simultaneously. Fluid levels reduced by the diuretic. Internal filtration pressure altered by the ACE inhibitor. Blood flow into the kidney now restricted by the NSAID. Three separate mechanisms, three separate disruptions, all converging on the same organ at the same time. Research published in the British Medical Journal has identified this specific combination, diuretics, ACE inhibitors or similar agents, and NSAIDs, as a pattern associated with significantly elevated risk of acute kidney injury. Some researchers have informally referred to this pattern as the triple whammy effect in nephrology literature, and it's a term that reflects exactly how the compounding works. Not one blow. 3. Landing on the same target. And the reason this catches so many people off guard is simple. Nobody prescribed the ibuprofen. Nobody reviewed it against the other medications. Nobody considered it a clinical decision because it didn't require a prescription. It was just something for the pain. But inside the kidney, it was the third weight on a scale that was already tipping. A study in the American Journal of Kidney Diseases found that NSAID use in older adults with existing cardiovascular medication regimens was associated with a substantially higher rate of kidney function decline compared to those not using them. Substantially higher. From something most people don't even consider a medication in the clinical sense. That's the part of this story that changes how you think about everything sitting in your medicine cabinet, not just what was prescribed. So now, you have all three pieces. A diuretic quietly draining fluid, reserves the body can barely afford to lose. An ACE inhibitor, shifting the delicate pressure balance that kidney filtration depends on. And an NSAID, restricting the blood flow that keeps the entire system functional. Three separate medications, three separate mechanisms. And here is where the real story begins. Because the danger was never about any one of them. It was always about what happens when all three converge inside the same organ at the same time. Think about it this way. Imagine a bridge engineered to carry a specific load. One car crosses no problem, two cars still within tolerance. But place three heavy vehicles on the same point simultaneously, and the calculation changes entirely. Not because any single vehicle was too heavy on its own, but because the structure beneath them was never designed to absorb all three at once. Your kidneys are that bridge. And right now, for a significant number of adults over 60, all three vehicles are crossing at the same time every single day, without anyone monitoring the weight. Here's what the science says about that. Research published in the British Medical Journal examined the combined use of diuretics, ACE inhibitors, or similar agents, and NSAIDs in older adult populations. The findings were striking. Patients using all three simultaneously faced a dramatically elevated risk of acute kidney injury compared to those using one or two of these medications. Not a marginal increase, a dramatic one. And acute kidney injury, even a single episode, doesn't always resolve cleanly. Studies in nephrology literature have shown that even one acute kidney injury event can accelerate the trajectory toward chronic kidney disease, permanently reducing the functional ceiling your kidneys can reach. One episode, lasting consequences. But here's what makes this combination effect particularly difficult to catch. Each medication was prescribed by someone with good intentions. Each decision made complete sense in isolation. The blood pressure needed managing, the fluid retention needed addressing, the pain needed relief. Nobody was wrong, but nobody was looking at the full picture either. This is what physicians sometimes call the problem of fragmented care, where multiple providers, multiple prescriptions, and multiple decisions exist in separate conversations that never quite meet in the same room. And in that gap between conversations, the kidneys carry the weight of everything that went uncoordinated, silently, consistently, without a single complaint. Until a creatinine level rises slightly on a routine lab panel. Until an eGFR number dips below a threshold that finally makes someone look closer. By that point, the combination effect has already been at work, sometimes for months, sometimes for years. This isn't about blame. It's about understanding that the most significant risks in medicine are rarely dramatic. They're quiet, they're cumulative, and they build in the spaces between what everyone assumed someone else was watching. Everything we've discussed so far has one thing in common. The diuretic quietly draining, the ACE inhibitor shifting pressure, the NSAID restricting blood flow, the combination effect building silently beneath the surface. All of it happens in the same dimension, time. And time, when it comes to kidney decline, is the variable that changes everything. Let me paint you a picture. A man in his early 70s, retired, active for his age, takes his medications every morning without fail, because that's the kind of person he is, responsible, consistent, doing everything his doctor asked of him. His blood pressure? Controlled. His energy levels? Reasonable. His daily life? Completely normal. Nothing hurts. Nothing feels different. No alarm has sounded because no alarm exists for what's happening inside his kidneys at this stage. Then one afternoon, during a routine checkup, not an emergency, not a crisis, his physician reviews a standard metabolic panel, and there it is. A creatinine level slightly higher than his reading from 18 months ago. An eGFR, that's the measure of kidney filtration rate, that has quietly drifted downward, not catastrophically, not dramatically, but consistently, in one direction, over time. Nobody caused it deliberately, nobody missed an obvious sign. The timeline had simply been running quietly, invisibly, while everything on the surface looked perfectly fine. This is not a rare story. Research published in the Clinical Journal of the American Society of Nephrology found that gradual kidney function decline in older adults on multiple cardiovascular medications frequently goes undetected for extended periods. precisely because the early changes fall within ranges that don't immediately trigger clinical concern. The numbers shift, slowly, just beneath the threshold that would make someone act. And here is what makes that timeline so significant. Kidney function, once lost, does not return. Unlike the liver, which holds remarkable regenerative capacity, kidney nephrons, the microscopic filtration units doing all the work, do not regrow. When they're gone, the remaining ones compensate. They work harder, they pick up the load, until there are too few left to compensate adequately. This is why the timeline matters more than most people realize. The difference between catching this early, when the eGFR is at 68, and catching it late, when it has dropped to 45, is not just a number on a chart. It is the difference between intervention and management, between slowing a process and simply watching it. A study in nephrology dialysis transplantation confirmed that early detection of medication-related kidney stress before significant function loss occurs is associated with substantially better long-term outcomes. Substantially better. Not slightly, substantially. Which means the most powerful thing you can do right now has nothing to do with changing your medications. It has everything to do with knowing your numbers. Before the timeline gets any longer, so here we are. Everything you've heard today, the diuretics, the pressure shifts, the hidden risks most people carry unknowingly. For years, none of it was shared to frighten you into inaction. And now comes the part that actually matters. What do you do with this? Because everything we've discussed, the diuretics, the ACE inhibitors, the NSAIDs, the combination effect, the invisible timeline, none of it was shared to frighten you into inaction. None of it was designed to make you distrust your doctor or abandon your prescriptions. Quite the opposite. This was shared because informed patients get better outcomes. Full stop. That is not an opinion, it is one of the most consistently supported findings across decades of medical literature. So let's talk about what informed looks like from this point forward. The first and most immediate step is knowing your numbers. 2 specific values, that's all. Your creatinine level and your eGFR glomerular filtration rate. These are standard markers measured through a basic blood test, and together they tell the most accurate story available about how well your kidneys are currently functioning. If you haven't had these checked in the last 12 months, and you are over 60, managing blood pressure, and taking any of the medications discussed today, that conversation with your physician needs to happen soon. Not eventually. Soon. The second step is complete medication transparency. Every over-the-counter medication, every supplement, every pain reliever taken occasionally for a sore back or an aching joint. All of it needs to be on the table during your next appointment, because as we've established, the most significant risks don't come from prescriptions alone. They come from the full picture that nobody has yet assembled in one room. The third step is hydration awareness. Not obsession. Awareness. If you are on a diuretic, your fluid balance requires more conscious attention than the average person your age. Research consistently shows that older adults underestimate their hydration needs, and even mild chronic dehydration amplifies every risk we've discussed today. And the fourth step, perhaps the most important of all, is simply this. Ask the question. At your next appointment, look your physician in the eye and ask, given everything I'm taking, when did we last check my kidney function, and is it time to check again? That one question, calm, informed, direct, is the difference between passive patient and active participant in your own health. Your kidneys have been working for you every single day of your life without asking for anything in return. This is your opportunity to finally return the favor. Not with fear, not with panic, with awareness, with action, with the kind of informed attention that changes outcomes before outcomes need to be changed. Thanks for watching all the way through. Staying informed is key to living a healthier, longer life. If you want more simple, practical health advice, make sure you subscribe and tap the next video on your screen. And, before you go, leave a comment and rate this. From 1 to 10, your feedback helps me create better guidance for you.